Ladies and gentlemen, in the world of clinical medicine, experience and evidence has helped in resolving the secret about certain black holes. Let's call this as clinical black holes. One of the black hole in the management of hypertension was systolic hypertension. As per the American Journal of Medicine 1988, individuals with diastolic blood pressure greater than 100 mm of mercury warrant treatment. Most recommendations were based upon the diastolic blood pressure, although the systolic pressure was considered at least as a good indicator of risk. But today, systolic hypertension has received significant importance because it alone, despite normal diastolic blood pressure, is considered to be a risk factor for cardiovascular mortality as per JNC6. And the medical fraternity is resolving this black hole by addressing a major issue called isolated systolic hypertension. Similarly, another black hole that appeared in the management of dyslipidemia was triglycerides. As per first NCEP guidelines in 1987, the major emphasis for managing dyslipidemia was on primary prevention and dietary approach. Further, in 1993, the second report of NCEP shifted their emphasis on secondary prevention with a special emphasis on low-density lipoproteins. But today, hypertriglyceridemia is emerging as an independent risk factor for hyperglycemia and cardiovascular mortality. Thus, today the focus is on triglycerides also. Apart from low-density lipoproteins and high-density lipoproteins, and the world of clinical medicine has successfully resolved this black hole called hypertriglyceridemia. Ladies and gentlemen, today, understanding of yet another black hole in the world of medicine becomes important. And the black hole is postprandial hyperglycemia. In 1996, as per current therapy, glycemic goals that were recommended to be achieved were fasting glucose level, evening glucose level, glycosylated hemoglobin. But today, clinicians have observed that even when patients have normal fasting glucose levels, the diabetic complications have been prominent over a period of time, thus raising an obvious question: why is it so? Let's see what great authorities have to say about this. Jocelyn's 13th edition comments that today more attention should be focused on the abnormalities of the post-absorptive state of non-insulin dependent diabetes mellitus and impaired glucose tolerance. The DCCT, Diabetes Control and Complications Trial, further confirms that the risk of complications may be more highly dependent on the extent of postprandial excursions. Also, DECODE, Diabetes Epidemiology, collaborative analysis of diagnostic criteria in Europe demonstrated that fasting glucose concentrations alone do not identify individuals at increased risk of death. It is postprandial too. The above comments thus point to existence of yet another black hole called postprandial hyperglycemia. Many leading authorities today have recommended the management of this black hole called postprandial hyperglycemia. The UK has recommended tight control of both fasting plasma glucose and postprandial glucose to prevent complications. The Diabetes Care has confirmed that patients with postprandial diabetes exhibit increased rates of microvascular disease and elevated glycosylated hemoglobin. Early control of postprandial glucose could possibly prevent or delay the progression of frank fasting hyperglycemia. So, ladies and gentlemen, to dispel this gloom of postprandial hyperglycemia, here is a star born. Natstar, natiglanide from IPCA 3C. Natstar dispels the gloom of postprandial hyperglycemia.